Hi everyone, my name is Yasuko Nagasaka from Tokyo Women's Medical University, and it is my great honor to be here. Thank you, May and Megan. It's such a wonderful group of people, the APSF family, and I'm part of it. So I'm going to start. This is my COI, and I am going to present two different research topics, and part one will be the maternal mental health, and the part two will be the pediatric neuroprotection. It's kind of different, but it's like a two sides of coins. Moms and babies always matter together. So as a background, I would like to mention these two articles indicating reduction of the risks for postpartum depression by giving labor epidurals. And the upper paper from 2014, the Dink et al. Reported that women who received the epidural labor analgesia had significantly lower incidence of postpartum depression, 14%, whereas compared to the ones who did not, 34.6%. So that's a big paper that everyone cited. But after that, the meta-analysis came out, and this shows that the results from this meta-analysis that conflicts what were previously published. And the study concluded that the labor epidurals were not shown to protect against the development of postpartum depression. But we should be cautious about the data because as current modern medicine does not allow pure non-analgesic labor. So unless the countries like Japan, where OB anesthesia is still not a standard care for the patrients for the vaginal delivery, so these might not be a good control group to draw out the conclusion. So what is unique about Japan? Because I practice in both countries and I'm board certified in both countries, so I can see through my different sets of eyes. And I would like to mention how we're doing in Japan. So this figure shows that the provision of labor epidurals in our patient population is pretty low. So although there's a great gradual upwards trend, the reported rate in 2023 was just 11.6% across the country. So almost half are done in small clinics with a single provider model by obstetricians, which is another different big topic, which I will not go into for today, but they provide labor analgesia by themselves. And this indicates that there are not enough anesthesia providers available in our country. So on the other hand, you can see what we do have for the pure control group who does not receive analgesia during labor and delivery besides the local anesthesia infiltration. So it occurred to me when I went back to Japan in 2016 that we should study our patients. So what is also unique about Japan is that, as shown in this figure, suicide has surpassed all other causes of death, such as hemorrhage, AFV, or intracranial hemorrhage, becoming one of the leading causes of maternal mortality. In 2022, it was as much as 23%. And the literature suggests suicide rate increases with maternal ages in Japan. So furthermore, many of the suicides occur during the postpartum period, which highlights the issue of postpartum depression. So this study that we did is to investigate whether women who received labor epidurals have lower risks for postpartum depression than women without labor epidurals and cesarean section in Japan. So we have presented this data at the ASA last year. And this is a single-center perspective observational cohort study, and we include women above 18-year-old with uncomplicated singleton pregnancies. We used surveys with a questionnaire which they completed at the start. That was around 35 weeks of gestation. The EPDS score, that was for the postpartum, but they can use for the prepartum as well. And we followed up the patient at 3, 6, and 12 months postpartum. And this included their scores on the EPDS, and we also gathered information about the maternal, infant, and anesthesia from their birth record and the electronic chart. And the primary outcome was the EPDS score at 1 month. And these are the patient characteristics for the 3 delivery modes: vaginal without labor epidurals, cesarean, and vaginal with labor epidurals. And there were significant differences in age, baby weight, and satisfaction with pain management during delivery between the 3 delivery modes. As you can imagine, vaginal delivery without labor epidurals had the worst satisfaction on the pain control here. And these are overall results of the EPDS score. Women with positive EPDS scores of 9 or above was 9.4%. And then at 35 weeks, so pre-partum, and then 10% at 1 month, so almost no difference, and then 5 to 6% thereafter. And significant differences were noted only in antenatal EPDS positive rate and the antenatal EPDS score. And multiple regression analysis with the EPDS score at 1 month postpartum was at the dependent variable was used to evaluate the impact of multiple factors on postpartum depression, and BMI, and administration of the labor epidurals, and antenatal EPDS scores were significantly associated with higher EPDS scores at 1 month. Bless you. In the Japanese population, these results suggest women who received labor epidural may have higher risks of depression at 1 month postpartum. And higher antenatal EPDS scores were predictive of higher postpartum depression risks at 1 month. And we have almost finished the study and now in preparation for submission. So I would like to thank Dr. Fujita for doing all the work. And the second half is about the pediatric safety in anesthesia. So this is a statement about the use of anesthesia medications in pediatric populations, and the SMART statement came in out in 2015. So in 2016, the FDA published new warnings about the usage of anesthetics and sedation drugs in young children and pregnant women. And they revised the safety communication, included they suggest postponing scheduled surgeries to be performed after reaching 3-year-old. So the researchers in Boston and across the world did the first prospective clinical randomized controlled trial to explore the effects of anesthetics on the developing brain in humans. And this is an international, multi-center, randomized controlled trial, including 28 hospitals in these countries, including the one in the US, Europe, Australia, and such. And so for the control group, they got the regional anesthesia plus sevoflurane, maximum of 8.0%, which is pretty high. And the intervention group got the regional plus awake. And they evaluated the neurodevelopmental outcomes at 2 years of age, which was a secondary outcome, and 5 years of age, which was a primary outcome. And after 2 years, the Bailey scales and MacArthur-Bates score revealed that they were not significant. And at 5 years, they used the WIPC 3 scale IQ score, and again, the results were not significant. So the lessons from the GAS study is that slightly less than 1 hour of GA in early infancy did not cause the neurodevelopmental problems at 2 or 5 years, and which means that they were, we did not change anything that we were doing, and we could keep on giving the anesthetics as necessary to our patients. However, when I went back to Japan in 2016, there were so many little children crying in the PACU, like having emergency agitation or delirium. And back then, the SMART statement was not fully disseminated in the country of Japan. So pretty small children getting surgery, like mole removal or such, And I thought that might be the reason that the kids are having delirium after surgery. So here are my questions. Why are small children develop emergency delirium agitation after the general anesthesia? And when you go back to this article from 1953, which was published in a journal and later became JAMA Pediatrics, and they used a questionnaire mailed at 2 months after the operation, and they checked the personality change, including nightmares, temper tantrums, bedwetting, afraid of strangers or new odors. And here are the results. A single-center prospective observational study over 18 months period, and the kids had ether for the anesthesia, and after the otolaryngological operation. And they found that the x-axis is the age, towards the left is the younger, and the y-axis is the percent change in the personality. And they found that the incidence of personality change was highest in the youngest children. And also, the literature suggests the prevalence of emergent delirium is about 18 to 30% in children. And here are some important features emergent delirium summarizes in slide in this review article. So probably in preschool children, 1 to 6 year old, with anxiety, presents with high intensity of anxiety after sevoflurane or desflurane anesthesia. It included pain or no painful procedures, and prevention included as such. So it occurred to me that the depth of anesthesia might be too deep in our patient populations. And we can monitor the depth of the anesthesia by using EEG, right? So we decided to use the EEG to titrate the depth of anesthesia, sevoflurane anesthesia, in our patient populations. The EEG signal is composed of different frequency waves, and the machine separates that. And when you get the raw EEG, and the machine separates that, and they color code by the organization of frequency magnitude. When you have much waveform, the higher power, then it gives you the warm color. If you have less, then it gives you the cold color. And then when you add up according to the time, then you get this nice screen to help you analyze the waveforms by color coding. And when you give propofol to adult population, like infusion of the propofol, and this is the time for the x-axis, and then LOC means loss of consciousness, and ROC is the return of consciousness. And when you are under propofol anesthesia, you get the alpha wave and delta wave, to be simple. And of note, EEG during anesthesia are different between the ages of patients. And this is an article studying sevoflurane anesthesia using the EEG. And alpha wave is only observed after 6 months of age. And that's why we decided to study the age between 1 through 6 year old. So using this EEG tool, I will give you some literatures from the pediatric population, then move on to the studies that we did. And since we're going to review some papers, I'm going to highlight we're using this fish going upwards as a positive study, and then negative study is horizontal, okay? So let's move on. This is an RCT published in 2022. They studied 220 patients rather getting EEG-guided anesthesia or standard anesthesia care, and the result has been shown as here. So they used the indexed number rather than reading the raw EEG or the DSA, the color coding waveforms. So there was no statistically significant difference between the PAED scores between the two groups. So it was a negative study. And here's another article, an RCT studying 40 pediatric patients undergoing ophthalmology surgery, and they are the high candidate for the PAED. and EEG-guided BIS management. So again, they used the indexes number for the high normal BIS of 55 to 60 or versus low normal 40 to 45, which is the deep anesthesia. So they compared the light anesthesia versus deep anesthesia and see what happened. So here are the results. So end-tidal sevoflurane concentration titrated to BIS did not reduce PAED mean score. So it was again the negative study using the index number. So we have learned that the emergence delirium may correlate with epileptic EEG in children with deep general anesthesia in other articles. And EEG-based approach may reduce requirements for sevoflurane anesthesia. And EEG-based intervention by PSI or BIS indexes, the numbers in children did not reduce PAED. So we did an RCT. So we performed a RCT to investigate the effects of reduced anesthetic exposure on PAED, and we recruited 200 children aged 1 through 6 without neurological issues at baseline, who are scheduled to undergo general anesthesia for more than 30 minutes for the procedures allowing reliable anesthesia such as local or regional blocks, plus remifentanil infusion. And our patients were randomized to intervention or control group. The control group received standard sevoflurane anesthesia with fixed level of sevoflurane, induction of 5% and maintenance of 2.5%. And then the intervention group received sevoflurane anesthesia titration by the EEG, whereas the control group received such. And the primary outcome was the proportion of patients with a PAED score of 10 or greater. And the secondary outcomes included the actual PAED score, as well as the sevoflurane exposure, time to emergence, and length of PACU stay. And in order to test our hypothesis, I asked Dr. Emery Brown to accept my fellow Kyo Miyasaka. Dr. Miyasaka, who is very well known to the APSF world, he was his son. And Kyo became Dr. Brown's research fellow for 2 whole months, and Dr. Brown kindly taught him how to read the pediatric EEG. And then he came back to our hospital, but we did not have enough pediatric patients. So he went to study with Dr. Suzuki, who was the chair back then in the National Children's Hospital, the biggest children's hospital in the whole country of Japan. And he did the study. So we recruited 218 patients, and the final number of the patients were 91 in the EEG-guided group and 86 in the standard practice group. And here are the example of DSA in pediatric patient undergoing sevoflurane anesthesia from the left to right. So awake state, induction is pretty deep, and maintenance, we maintain the patient under anesthesia by EEG guidance with the delta wave and alpha wave. And if it gets too lighter, then you increase the sevoflurane dosage. If it gets too deep, then you will decrease the sevoflurane dosage. And here are the results. So the incidence of PAED was lower in the EEG-guided group compared to the control, and the overall incidence of PAED was about 30%, which was consistent with the previous reports. And the table on the left shows the number of patients in each group above and below a PAED score cutoff of 10. And the box plot on the right shows the maximum PAED score for each group. And on average, the patients in the EEG group were exposed to less than half of amount of sevoflurane. I'm going to skip these slides because the time is coming. And what we found is that with EEG, patients emerged about 25 minutes faster, and they discharged about 20 minutes earlier from the PACU. So in conclusion, we were able to reduce PAED by controlling exposure to sevoflurane by EEG-guided titration without compromising surgical anesthesia. EEG-guided titration of anesthesia also led to faster immersions and shorter PACU stays. And it may be possible to greatly reduce sevoflurane use in pediatric anesthesia with EEG guidance and multimodal anesthesia techniques. But the most importantly, it's not just a matter of placing the sticker over the forehead, but the largest next step is to learn how to read it. So I would like to thank everyone for listening to me, and I will take any questions if you might have. So thank you so much.